A pregnant woman sits in a clinic waiting room. She feels completely fine, with no pain or discomfort. But her routine urine test comes back positive for a bacterial infection. Normally, a bacterial invasion of the urinary tract triggers unmistakable alarms: burning, severe urgency, and sharp pain. During pregnancy, the body's immune responses and physical sensations shift, frequently suppressing those usual warning signals. Doctors call this asymptomatic bacteriuria. Bacteria from the digestive tract migrate into the urinary system and quietly colonize the area without causing a single noticeable symptom. This lack of discomfort is deceptive. The absence of physical pain does not mean the absence of an active, spreading infection. If left alone, these silent bacteria migrate upward from the bladder, through the ureter tubes, to infiltrate the vulnerable kidneys. Once lodged, they trigger acute pyelonephritis. This localized damage rapidly cascades into maternal sepsis and systemic shock, creating a life-threatening emergency. This intense maternal inflammation quickly crosses over to threaten the fetus. The resulting systemic stress frequently triggers premature rupture of the amniotic sac and forces early preterm labor. Screening for silent bacteria provides a critical, time-sensitive window to stop a localized issue before it escalates into a dual patient emergency. To understand why this escalation happens so easily, we have to look at how pregnancy inherently compromises the urinary tract's natural mechanical defenses. Pregnancy hormones, specifically progesterone, cause the smooth muscles of the ureters to relax. Instead of their usual rhythmic pumping motion that forces liquid downward, the tubes become loose and sluggish. At the same time, the physical weight of the growing uterus bears down on the pelvis, heavily compressing the bladder and pinching those ureter tubes. This combination of relaxed muscles and physical compression creates stagnant pools of urine inside the system. The liquid slows down, allowing any bacteria present to rapidly multiply unchecked. A healthy pregnancy re-engineers the body's internal plumbing, inadvertently creating an ideal breeding ground for hostile bacteria. Not every extra bathroom trip is a cause for concern. A growing baby pressing on the bladder naturally causes frequent urination. But if that frequency comes with a sharp burning sensation or a severe urgency to go, even when the bladder is empty, those are clear warning signs of cystitis, a symptomatic bladder infection. This clinical chart outlines the differences between an infection confined to the bladder versus one reaching the kidneys. If symptoms escalate to include fever, chills, severe nausea, and flank pain, the bacteria have breached the upper urinary tract. Certain mothers require even higher vigilance. Those with conditions like diabetes, sickle cell trait, or a history of recurrent infections face a significantly elevated risk of rapid bacterial growth. When a test comes back positive, doctors use a targeted urine culture to identify the exact bacterial strain. This maps out the pathogen's specific vulnerabilities, allowing for precise antibiotic selection. Many expect to avoid all medication during pregnancy, but leaving an active bacterial infection untreated is deeply hazardous. Specific, targeted antibiotics prescribed by a doctor are biologically safer for fetal development than allowing a pathogen to spread unchecked. If symptoms vanish after 2 days of pills, stopping the medication early is a major error. Cutting the treatment short leaves the hardiest surviving bacteria alive, selectively breeding an aggressive, antibiotic-resistant colony. Finishing the entire antibiotic course creates the biological shield necessary to protect the pregnancy. After the last pill is taken, there is one final medical requirement: the test of cure. This is a mandatory follow-up urine culture. Because pregnancy suppresses symptoms, feeling better is no guarantee of health. This biological verification is the only way to confirm that the silent bacteria have been entirely eradicated from the tract. Between clinic visits, consistent, high-volume hydration acts as a mechanical flush. Pushing 2 to 3 liters of water through the system forcefully sweeps away unattached bacteria before they can settle and colonize. Other strict behavioral defenses are just as crucial. Never holding urine, voiding immediately after sexual intercourse, and wiping from front to back physically prevents fecal flora from migrating toward the urethra. These habits serve as active mechanical defense systems deployed against microscopic invasion. And while alternative remedies like cranberry juice are popular, they have severe biological limitations against an active, entrenched infection. An acidic environment might make it harder for new bacteria to attach to the bladder wall, but it cannot destroy a colony that has already breached the body's defenses and started to multiply. Back at the clinic, the mother leaves with her prescription and peace of mind. Her compliance with routine testing neutralized a threat before it ever manifested as a crisis. Relying on routine screening and evidence-based medicine makes an invisible, high-stakes threat entirely solvable.